So let me tell you a little story about the power of a single tablet in terms of just thinking about how mobility can change the way that we practice. So at our hospital in Westwood, we're well known for providing some of the top-of-the-line type of tertiary and quaternary care, and probably we're most famous for our liver transplantation services. So liver transplantation is probably one of our most complex surgeries, and the kinds of patients that undergo it and then what they go through prior as well as during and then afterwards can be quite complex. So nobody ever wants to be the interesting patient or the patient that all the house staff know. So there was one particular patient who had literally been in our hospital for 2 years. Now, in terms of just thinking about a length of stay, I know that Jerry is still here, so somebody does know the cost of what a day in the hospital is. Any guesses from the audience? People probably know. So just turning on the lights at a hospital is going to be $3,000 to $5,000. That's just sitting there in the hospital. That's not even including the care that we would provide. So in terms of thinking about this patient sticking around for 2 years is pretty incredible. And it wasn't as though this patient couldn't have left the hospital, but the patient didn't feel comfortable. Basically, the next stage of care that the patient really needed was to undergo rehabilitation so that ideally he could go home. But the problem is that in terms of the kinds of services that we would provide normally in an acute care hospital, we're not really set up to do rehabilitation. That's not what we do very well. And ideally, a patient should go to a rehabilitation facility. So what we did over time was to work with all the services to basically make an arrangement where we were going to give an iPad to a subacute facility so that our surgeons could check in on the patient basically once or twice a week just to make sure that things were fine and to guide the practicing providers at that subacute care facility in terms of any sort of changes that might happen, any sorts of things that they should be looking out for the patient, and just to make sure that that patient still felt connected back to our team. So that patient went out to San Pedro, which is sort of in the South Bay, maybe about 45 minutes out from where Westwood is, stayed there for 3 months and is now at home. And just thinking about just having that single iPad where all we were doing was essentially a video conference with the patient and with the providers really dramatically dropped the cost of care. Because I have to say that I don't think anybody from any of our surgical teams had any idea how we would be able to get this patient out of the hospital. And really, it's these type of solutions in terms of thinking about where we should be delivering care that can dramatically drop that cost curve that you heard earlier from Mark McClellan and from Jerry Kaminsky that will really drive the future of healthcare. Okay, so the invisible patient. So I have to say that in terms of thinking about the kinds of patients that we will be caring for going forward, it's really hard as we start thinking about population health. So the first time that I had to deal with a patient registry, I remember taking a look at my patient panel and thinking, who are these people that have hemoglobin A1Cs that are double digits? I'm a good doctor. What is going on? This doesn't make any sense. I don't even know who this person is, but this patient had been assigned to me just to never come into the office. So on one hand, I can provide the best kind of care possible for the patients who are coming into clinic, but for those patients who aren't there, it's a completely different story. And as we think again about how we're going to move into this world of accountable care organizations, as you heard a little bit more from Jerry, we have to think differently about how we will be potentially delivering care, and we need to be able to provide it where those patients potentially are. So I think the second facet of the invisible patient that I'd like to tell you a little bit more about is how I currently practice. So I probably am in clinic maybe about 4 to 8 hours a month. And it's just because I've had all these extra responsibilities and things like that that I've had to take on, I just can't really manage the patient population that I have. That being said, I did give all my patients these great options to tell them there are these great doctors that I know that I'd love you to work with. Nobody took me up on the offer. So I've been sort of limping along in terms of trying to figure out how I'm going to care for all these people who used to be my primary care patients, and literally, I have to think differently. So I do a lot of things that are asynchronous in terms of how we would potentially deliver care. Now, John did ask me to briefly talk a little bit about different modes of providing telemedicine. And at the end of the day, you can either do it in real time or you can do it asynchronously. So just like, for example, as you think about providing emails or contacting your loved ones or your patients, we can do the same sort of thing in medicine. And so that's what I essentially do in terms of my practice. I'm actually during lunch, I think I was prescribing medications to a patient literally on my smartphone to provide them the medications at their pharmacy. No human interaction required in terms of doing that, just a couple of messages back and forth. And as we think about how we need to reorganize care to provide those kinds of services, in terms of having a true face-to-face encounter, we really need to think about when does somebody really need to come into clinic to see me? When can we do this at the convenience of a patient, being at their home? When can we just do something asynchronously? What are really going to be those ideal types of modes of delivery? And that, again, gets back to John Matson's point earlier this morning. So the final thing I'd like to say about the invisible patient is that the most invisible patients are all the young individuals. They're all expecting care to be delivered this way. They're the ones who are basically telling me, I'm just seeing you because I needed to come in. I normally wouldn't have, but at the end of the day, I wasn't really sure exactly how to get care, and this particular person probably didn't figure out how to use some of the Live Health Onlines or Doctors on Demand or other types of services that are really out there to provide them urgent care services. But they will figure it out. Just like, for example, for all of us, in terms of how we now probably shop online, most people here probably use Amazon. When you first started thinking about how you would potentially buy things, probably a little uncomfortable, not totally sure if this is really going to be the right way to do things. Probably still felt like you wanted that personal experience. But I think that everybody feels comfortable about buying most things over the internet. So in terms of thinking about how we will deliver true wellness, any ideas what this figure is? Okay, I'm not hearing any comments. So a big discussion, and you heard a little bit about this earlier today as well, is about the patient-centered medical home. And this has been a big innovation in primary care in terms of thinking about how we should deliver care, and that we need to have team-based care. We need to have a group of people that are all in this medical home focused on delivering care to the individuals. And as you heard earlier from Mark McClellan, some of these have worked fantastically well. Some of these have not worked so well. And so this is an example of what's called the medical neighborhood, where not only is there a medical home, but there are all these specialists that are around in terms of trying to organize care around the single individual here. That all sounds great. I think that we definitely need more care coordination, which you also heard a little bit about earlier today. But I think that the biggest thing is that this is not how any city is set up when you really think about it. In terms of where we live or work or play, basically, it's a much broader arena. And so these services are really not localized like this. So no amount of people coming into clinic is really going to help us. As I mentioned before, the people who really need our services are those people who are not coming into clinic. So there was a research project that I was working on called Community Partners in Care, which worked on delivering evidence-based depression care services into underserved communities in Los Angeles. So we asked people, where do you get your health care? So most of the time they were not going to the primary care office. Sometimes they were seeing specialty mental health care. But in large part, they were going to churches, they were going to parks, they went to beauty salons. I mean, they're getting their healthcare information from all sorts of different places than we would normally think about healthcare and medical care delivery. And so as we rethink about how we should be patient-centered in terms of our delivery of care, we need to really think more broadly about where can we be with the patient. And I have to say that the one thing that I feel most anxious about is when I leave my smartphone at home. I don't know if anybody else feels that way. If I forgot my smartphone, I have to drive back home. Anything else, even a watch, that I can live with. But the smartphone, I'm in trouble. And I'm guessing that these days, 70, 80% of the population that has a smartphone, and again, most people do have smartphones, even in those individuals who are coming from lower socioeconomic backgrounds, have some element of a smartphone available to them. So in this age where that's the one thing that connects everybody, that's where we need to be. So in terms of thinking about being fully connected in terms of healthcare, you heard a little bit about sensors. I have to say that this conference that Bruce Hensel mentioned earlier at UCLA is pretty amazing. So just in terms of looking at some of these plugins that were developed by some of our electrical engineering professors at UCLA, literally they have these little plugins for the Android phone that will that will basically get down to the DNA level. And they're not that far away from being commercialized. So we were watching some bit of DNA swirl around in real time. And as we think about what that potentially means in terms of identification, all those things that John Matson talked about that he said was sort of 2020 but sounded Star Trek-ish, that sounded like it was way off in the future, literally we're probably not that far off from having that ability. And not only is that ability to sense things externally, as we think about at the conference that's basically down at the Sands, there's a ton of people there probably talking about wearable sensors and the kind of clothing that you actually can put on that will sense different types of things in terms of temperature changes, in terms of what your breathing is like, what your heart rate is like, that will basically be very unobtrusive. So I think that in terms of what those sensors can potentially provide, combined with what you heard a little bit about the Internet of Things, everything in our world is going to be interconnected. And this will provide us the opportunity, not only are we going to basically get information about what your health is like at this one point in time, as you drive around, we'll see what you're like as you're driving around in LA traffic, and we'll see your stress levels go way up. We'll see what you're like when you're going out to the store and buying junk food or whatever you're buying at the supermarket in terms of the kinds of things that we think will keep you healthy. And all that information can potentially be aggregated to make sure that that individual will get personalized care that's going to get them as healthy as possible. So it sounds like a fantastic future. The one thing I would say about all this new type of technology is that there are still some very simple, basic things that still make these things difficult to really work with. I ran a large study, which I think I'll tell you guys about, called Beat Heart Failure, Better Effectiveness After Transition for Heart Failure. So this was a large study that was conducted at all 5 University of California medical centers and also Cedars-Sinai Medical Center. As you heard a little bit about some of the health policy changes that have happened as a result of the Affordable Care Act, one of the big elements that hospitals all pay attention to is the readmission rate, because there's actually legislated in the Affordable Care Act financial penalties if your readmission rate is too high. And specifically, they're looking at patients with certain kind of conditions. So heart failure is one of the classic ones. And literally, if your readmission rate is too high, you're not going to be penalized on just the reimbursements for that set of patients alone, but you're actually penalized on a fraction of your entire Medicare reimbursement. And that is huge. Now, on one hand, a lot of hospitals have not reached that inflection point where they really need to work really hard at reducing the readmission rates. We're still living in a model where we're still getting paid to, for example, still take care of people in the hospital. So at some point, you have to weigh how much are you getting for every hospital admission and how much are you getting potentially penalized at a readmission. But those penalty rates will continue to ratchet up. So at some point, all hospitals will start focusing a lot more on this. So we wanted to try to understand better how to use these new type of technologies. So this particular study had about 1,400 patients. I know that John did not mention this study. He mentioned Eric Topol's study, but this study literally just got published earlier this month in JAMA Internal Medicine. So this is pretty recent for those who hadn't heard about this particular study. So in terms of looking at the outcomes for the study, I'm not going to really go through any sort of graphs. Basically, there are 2 lines in each of these little boxes, and it doesn't look like there are 2 lines. So at the end of the day, what that means is that the patients that got usual care and the patients who got the intervention didn't really have any differences. Now, the intervention that we used for these patients was to basically give patients a blood pressure cuff that would measure their heart rate and their blood pressure. We gave them a weight scale and all this equipment, and as well as a text machine to basically answer some simple symptom questions. All that information would be sent via Bluetooth to a transmission device that would then get sent back to a centralized call center that then also checked out patients and followed, for example, how they were doing on a weekly basis after they left the hospital for the first month, and then for every month after that, they would do another check-in call. So it's a pretty intensive intervention. And as we think about the state of the art in terms of what we should be doing for heart failure patients, every cardiologist will tell you, we want our patients to weigh their daily weights. We want them to understand what their blood pressures are, what their heart rates are, because they're on a lot of medications. These are complicated patients, and we want to be able to act on that type of information. So in terms of thinking about why this particular, this particular study ended up with this particular result, these lines are looking at readmission rates and looking at mortality rates. No difference. It's not the most negative study in the area. We actually did have some positive findings about quality of life. But I would say that for the most part, when we've looked at a lot of remote patient monitoring studies, when we've put them to the most rigorous type of tests like this, like a randomized control trial, we haven't really seen the benefits. Now, the one thing I would say about the JAMA Internal Medicine article that we published, they actually asked us not to include this last slide, which we did present at the American Heart Association meeting in November. So this actually looks at what people's readmission rates were and their mortality rates were, depending on how much they participated in the intervention. So you can see that here that for those individuals who at least did 50% of the monitoring, so of the 180 days that we asked them to do things, because we asked them to do this every single day, you can see that their readmission rates, were 13%. For those individuals who participated less than that, about 35%. That is a huge difference. Now, when we look at the overall rate for these individuals, it's around 23%, and that's actually what we would expect for usual care. So those individuals who didn't actually participate seem to do worse. Same sort of thing when you look at the proportion of calls completed. So again, 15% in terms of their readmission rate at 30 days, and 30 days is the measure that most people will look at. And on the other hand, for those individuals who are participating, less than 50%, almost 35%. Same sort of thing for mortality. If you look at 30-day mortality, nearly negligible in terms of those individuals who are participating versus those who are not. Now, the one thing is that this is not a randomized controlled trial in terms of looking at these particular things. Now, you might say, well, those people who were able to participate more must have been healthier and they were able to do it. So we actually did adjust this measure to make sure that we took into account, for example, when people died. But it is a little hard to know for sure what else potentially could be going on. So were they just too sick to actually participate or not? Hard to know. Are these people who would have been compliant anyways? Hard to know. So I think it suggests that we still need more evidence out there and more studies to really understand how we need to use these type of devices. But I think that at the end of the day, adherence is really critical and patient engagement is really the most important thing. So I think that most people here probably, how many people go to the gym? I see hands. Okay, so I do see some hands. That's good. So in terms of going to the gym, I think everybody knows that if you go to the gym in January, it is packed. About now, kind of goes down. And then, starting next month, you can go anytime you want. Same sort of thing happens when you get activity trackers or a Fitbit or a Jawbone, whichever kind of device you like. Somebody gets it at Christmas. They are really excited about using it in January. February starts rolling around. And if it's a watch device, maybe you're wearing it. But if it's something that you had to clip on, probably not. So I think that again, in terms of thinking about these type of devices that we can use to monitor our health, part of it will really come down to how do we change people's behaviors to make sure that they really want to take on this kind of measurement. And I think it really gets back down to making being healthy a social norm. And if people are really engaged and people really want to be healthy, that's when we'll see much more adoption. Now, I did mention that there was one issue about these sensors going forward. So probably the biggest issue that we happen to see in terms of people using these devices or not was actually about their ability to actually get a connection and changing batteries. That just sounds like something that wouldn't make any sense. Changing AA batteries in a device shouldn't be so hard. But that actually was a technical problem that a lot of people said that they weren't able to handle. So as we think about these type of devices going forward, and having served on multiple review committees to look at some of these proposals at a national level for these new type of devices, finding some type of low-powered device that can automatically charge will be really huge. Because I think at the end of the day, you want something that is going to be unobtrusive. You want something that's just basically going to be in the background that you don't really need to worry about. If you have to keep changing the batteries every so often or taking it off and taking it on, that's not something that's actually going to really get you engaged. And I think that the other thing in terms of connectivity, so despite the fact that we're in the United States, when we compare ourselves to other countries, we are not as wired as other countries, is the bottom line. And so there are places in that map in West Los Angeles, which is considered a fairly affluent area, that we could not find any type of connectivity for individuals, no matter what cell phone carrier we went to, didn't have Ethernet, couldn't get them a phone line, and just couldn't get them connected. So I think that as we think about how we're going to use these type of devices in a mobile environment, we also need to think about where patients going to be, and are we really going to have an environment that's really going to fully enable people to use these type of devices to be as healthy as possible going forward. So this just happens to be our UCLA app, but there's always an app for everything. And I think that the one thing that we have really found is that there are too many apps that are out there to try to keep people healthy. So as we think about what we will be doing in the mobile space, there are a ton of things. If you go to, let's say, Google Play or you go to the iTunes App Store, there are a ton of different apps that are out there to focus on your health. Now, I have to say that innovation is actually about stealing great ideas from other people who come up with them and adapting them to your own environment. So I did see there are some people from Ochsner. People from Ochsner, are you still here? Oh, okay. Anyways, good. She doesn't have to hear this. So So as it turns out, in terms of how we're trying to deal with apps at UCLA, is that we've asked providers to actually review the apps to decide which ones are going to be best for their health. And this actually was an idea that we borrowed from Ochsner, where they actually have something called an OBAR, where they actually have a technology testing area that you can try out different types of things, see what sort of app works best for you, what other sorts of devices may potentially work for you, so that you can customize it to your own health. We actually have a similar type of place that's at one of our clinics up in Woodland Hills, which actually happens to be in a mall, Westfield Mall. And in the waiting room area, we actually have somebody there who can actually do the same sort of thing. And there's actually a list of different health applications that the providers there have actually gone through and done the reviews to decide which ones would they recommend. And I think that as we think about this going forward, again, in the age where we live in, where you can Google anything, what you really want is a filter, and that's really what healthcare providers will be doing going forward, because our patients really care about health. I think the one thing that I remember talking about natural supplements in the 1990s, I think everybody was shocked at how many supplements people were taking, but that's because we all care about health, and patients want to do, and people want to do, whatever is going to keep them healthy. And that's the reason why we go to the gym, the reason why we might take supplements, and people are going to look online to try to understand how they can be as healthy as possible. But when you're faced with information overload, whether it's coming from app bloat, just in terms of stuff that's preloaded on your phones, or again, as you're going to the store and just searching for something called health and getting 1,000 hits, they're going to need somebody to help make sense of it. And that's where, as healthcare providers, we will likely be coaches going forward in terms of making sure that people really will stay well. So the final thing I want to talk about is security. So this got mentioned a little bit earlier as well. I don't know if anybody knows which hospital this is. Any ideas? This is Hollywood Presbyterian. Hollywood Presbyterian was in the news because they were held hostage because their electronic health record got taken over via some ransomware, and since we talked about bitcoins earlier, they paid $17,000 in Bitcoin to get their electronic health records released. It was not Gary's former company. So in terms of thinking about security, this is a huge issue. So on the healthcare operations side, part of the reason why we've been probably slower than I would have liked to have seen us adopt a lot of these new type of technologies is because we are very sensitive to the fact that these are essentially open portals in terms of external individuals potentially getting into our electronic health record. And then because of HIPAA, we want to treat this as this type of information as securely as possible. We want this to be as secure as any type of other information that you want, and if anything, even more secure. So I think that in terms of thinking about how we can be secure in this digital age, when every other month I get a letter from some institution that got hacked and my social security number is out somewhere in the world along with other banking information and things like that, we need to try to find different ways where we can be secure. And I think that on one hand, we've been really great at UCLA in terms of trying to make sure that we have as secure environment as possible. So I think that most people at UCLA in the health system are deathly afraid of hearing a term called AirWatch. I don't know if people's companies also use that particular technology, but essentially it allows us to wipe the information on somebody's remote phone if you have patient health information. So in terms of how that will potentially interface with these new type of applications, or how we will be thinking about how this type of interoperability that we all want to see in terms of having your health information freely interact with the other types of information that are out there in the environment that we can get if we're truly in a mobile environment to really make you as healthy as possible, is something that I think that we're really going to have to work hard on and overcoming. And this is not something that is a healthcare institution that is really in our wheelhouse. I mean, at the end of the day, we're all about healthcare. We are not about having defense-grade security. So at some point, as an industry, healthcare is going to have to figure out how are we going to solve this type of problem in a way, and it may take a couple different solutions. Maybe it'll be a market solution. Maybe it'll have to be something mandated again, just like what happened with electronic health records. But at some point, we will need to figure out a better way forward in terms of security. So the final thing I just wanted to just briefly mention is that the future is here. So I have to say that in the study that we've conducted, you would think that maybe patient adherence or compliance with these type of interventions was different based on their age. That was not the case. Sometimes we would find that really old individuals actually knew a lot more about the devices, like for example being a retired electrical engineering professor, to tell us all the problems that we had with our devices and more. And I think that everybody would be quite surprised in terms of how much adoption is really happening among older populations. I was just talking with one of our endocrine surgeons who does a lot of our video visits, and he, again, was shocked at how many older individuals were able to do this kind of technology, which is not something that he would have expected. But if it's not the patient themselves who can work that type of machine or do the video visit, they have a loved one, a caretaker who can help them out. So I think that, again, in this type of era, we don't need to be so worried about patient adoption. I think patients are really out there wanting this kind of care. The other thing is that I stole this from a French website. And in terms of how we deliver care these days, it's truly global at this point. So I've certainly have taken care of patients who have been in other countries, and part of the reason I went to a French website is because I had to take care of a patient who spent half of his time in Lyon and was interfacing both with the French healthcare system as well as our healthcare system, and had to figure out how to coordinate their care. And at the end of the day, there's all these sort of problems, but if we're thinking about things in a patient-centered way, it doesn't really matter how we have those discussions. It's all about the patient. And ultimately, this is a people business in healthcare, and it all comes back down to that interpersonal relationship that we have as a provider with the patient.